As you get settled in, I'll take a moment to let you know a little bit about the International CML Foundation, who we are and what we do. So the International CML Foundation is a physician and researcher-based organization with two key priorities, both of them working towards improved outcomes for CML patients around the world. So firstly, the foundation is raising the bar of CML management through CML education, and that includes meetings like this. Over the last 15 years, the foundation has been working via preceptorships, meetings, symposia, and online, for example, with the Knowledge Centre, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of the foundation's work is harnessing the power of global research. The ideal, of course, is a cure for CML, but along the way, they are trying to improve treatment pathways, the patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance. They did a lot of work around CML and COVID. There's a hepatitis B survey out there, and they're looking at pregnancy in low and middle income countries, pediatric treatment in low and middle income countries, and much more to come. So that's a brief overview of the International CML Foundation, who they are, what they do. Let's move on to our topic for today, which is difficult cases from across the region. And we have some really excellent and very challenging cases to share with you. I'll introduce our speakers today. So our experts today, I'm really delighted to introduce Professor Mhairi Copland from the UK. Professor Mhairi is a globally renowned hematologist and professor in translational hematology at Glasgow University. Mhairi is a great friend and contributor to the International CML Foundation, and it's really lovely to have you here today. Thank you, Mhairi, for also stepping in and managing the waiting room. From India, we have Professor Digumarti, who, amongst many other things, is a senior consultant and medical oncologist who has pioneered cancer treatment, research, and education in the state of Andhra Pradesh in India by building a comprehensive cancer care center at the Nizam's Institute of Medical Sciences in Hyderabad. And he's worked with the government to bring optimized cancer care for people living below the poverty line. Welcome, Raghu. It's an absolute honor to have you here.
Thank you.
I am also very pleased to introduce Professor Mhairi Khan from the Armed Forces Bone Marrow Transplant Center in Rawalpindi in Pakistan. Now, the foundation very first got to know Mehreen when she did a preceptorship at the MD Anderson in Texas in the USA with Professor Jorge Cortez, and she's been a friend to the foundation ever since. A leading woman in the field, and we're delighted to have you in the hot seat today. Welcome, Mehreen. Our fourth expert today is Dr. Jeff Lipton, and I'm not sure if Dr. Lipton has yet been able to join us. I hope so. If not, we will welcome you very soon. But it's a great pleasure to have Dr. Lipton from Toronto in Canada. Again, giant in the field and the foundation's go-to person for really difficult cases and the questions that have other people scratching their heads. He is trying to retire, apparently, but I always hope that that just means he has more time to contribute to the foundation and to events such as these. So it's such a privilege to have you here today. Welcome, Jeff, I hope, when you join us in the room. Okay, so I will take my slides down and I will invite Raghu, please, to get your slides up, and we will move on to your first case.
Good evening or good morning, everyone. I'm presently at the MNJ Institute of Oncology, which is a regional cancer center at Hyderabad in the other state, the state of Telangana, which was originally a part of Andhra Pradesh. So here is my first patient. She's a 37-year-old lady who was already on treatment for chronic myeloid leukemia since 2018, and she presented with melee, weakness, facial puffiness, and increasing pallor for about a week. So her investigations at this time showed she had anemia, 7.2 grams. She had a low WBC count, 2,950, with an absolute neutrophil count of 1,570, The platelet count was 1,14,000. Serum chemistry was normal. BCR-ABL again this time was 33%, but what we noticed from 2018 was that she never achieved a major molecular response during the entire treatment. The bone marrow aspiration and biopsy along with flow cytometry showed a CML in myeloid blast crisis. We also did a BCR-ABL kinase domain mutation, which was negative. It has been done in the past 3 occasions. We repeated it again and it is still negative. And we did a cytogenetics as well. There are no additional cytogenetic abnormalities. She was put on nilotinib for a year initially, and she was switched to dasatinib 100 milligrams daily, even though the IRMA was negative. And she required dose reduction to 75 milligrams and finally to 50 milligrams in view of persistent cytopenias. She wasn't tolerating dasatinib because of the cytopenia. She was hardly ever on the drug, and months went by without her taking the treatment, so she was shifted to imatinib 300 milligrams. And presently she is in myeloid blast crisis. So we have the following dilemmas in her. She is not tolerating the required dose of a TKI, never attained a major molecular response, although she was drug compliant as far as permissible. The mutation analysis is negative, but the bone marrow shows a myeloid blast crisis. So with no mutation detected, what's the road ahead for us? I can stop sharing my slides so that we can have a discussion.
Mhairi, what do you think?
So I think this is a really difficult case. It's a young woman who's never really had a proper response to her CML. I wondered, did she have cytopenias on the nilotinib as well from the start? Has that been a long-standing problem?
Yes, that has always been a... So whatever was the tyrosine kinase we have used, we noticed that she always had the counts on a lower side. Initially, we thought this was because of a high tumor burden. And what little count we are seeing is the actual normal cell, which was quite all right on the differential count. We didn't find myelocytes, metamyelocytes, or promyelocytes. So we were quite happy thinking that this is expected because most of the cells are pH positive and they're getting eliminated. But the persistent low count since 2018, it's about 7 years now, is pretty worrisome. So it never actually recovered back to normal. It never actually crossed 4,500.
And now that she's in blast phase, has she got high counts or is she pancytopenic?
She is still pancytopenic. She doesn't have a high count. The counts I have given are this week's counts.
Okay. I mean, if this was my patient and her bone marrow was showing blast phase, I would be giving her myeloid blast phase. I would probably want to give her AML type chemotherapy.
Okay.
And then probably with ponatinib, and then work her up for bone marrow transplant, assuming she's got a suitable donor. Would be how
so we can plan the 3+7 induction. That should not be a problem. That's quite routine for us for myeloid blast crisis in CML. So adding ponatinib, I was always a little bit hesitant about that because of it complicates, it's almost like giving chemotherapy. So sometimes we use, I still remember the iCMLf preceptorship when I first noticed it's used in a clinical trial in Portland, and it used to wipe out the marrow. So that used to be a major problem. So I was a little bit hesitant. Do you want me to first start the ponatinib, or do you want me to first start the 3+7 and then slowly add the ponatinib?
I mean, I think in her case, because she's pancytopenic and her marrow's full of blasts, I think it's important that she gets the chemotherapy first.
Okay.
So the 3+7, we would tend to use FLAG-IDA, but I think 3+7 is as good. And then add in the ponatinib afterwards if you need to hold her with something to get her to transplant, would be how I would do it.
Majority of the time, we often find in myeloid blast crisis in CML that they don't ever enter a remission. Sometimes that is pretty worrisome. And doing a transplant when you have full-blown disease often complicates the matter even more.
I think she might be one of these poor patients that has no normal hemopoiesis left, so that you're never going to clear it. So maybe giving her a new immune system, if you can get her back into a second chronic phase, it is really the most important thing to do. So getting her back to a second chronic phase and then a transplant, I think would be what I would do. But other people may have other opinions. I think Newman's asked a question online, so they're asking how about checking TKI domain mutations, and I think you'd done that and there were no mutations on the dasatinib. Is
No.
that correct?
We have only checked for imatinib resistant mutations, and of course we did cytogenetics this time just to be very sure that we didn't miss something on the PCR. So we don't have a mutation in the cytogenetics, and we don't have an IRMA as well.
I might take this opportunity to ask Professor Ali Khan to give us her view. I could see you nodding quietly in the background there. What do you think? What would you do if she was your patient?
Thank you, Lynn. Thank you, Professor Raghu, for a very wonderful case. We come across such cases very frequently. So when we started transplant in our institute 25 years ago, we used to transplant every CML because TKI was so expensive that we would prefer transplant in chronic phase as well. And then gradually, with the passage of time, with the availability of first line, second line, third line, and now fourth line TKIs, the transplant are limited. However, our institute has done most transplant in CML, that is 110 in chronic myeloid leukemia, with 50% of them being in blast crisis. So had she been my patient, she's a young patient, 37 years old, having CML since 2018, that makes 7 years of agony with CML. So I would, if her ECOG performance status is well, I will give T3A7 with ponatinib for induction. I will check the status. If she's in CR2, I would like to take her to transplant, but with fully HLA matched donor. However, with haplo-matched donor, I would be a bit hesitant. CML is notorious for GVHD with fully matched donor as well, but with haplo-matched donor, we have faced quite problems in other disorders as well as CML. So if she has haplo-matched donor, I would think a bit. If a fully matched donor is available, so the patient should be taken to transplant. And there's no other way because it's myeloid blast crisis. And then post-transplant, 2 years post-transplant, we would like to continue with ponatinib. So we have done many cases of CML. So this is all from our, and if the patient is frail and cannot tolerate a DAW, then we'll give a hypomethylating agent with venetoclax and with TKI to achieve CR2.
Raghu, how does that sound?
Yeah, that sounds good. We do typically use in the elderly azacitidine plus venetoclax, and we have had very good results pushing a few of them to transplant later. We have started using it in the pediatric age group also for children with AML and ALL who don't go into a remission. So we have good experience with that, and we are sending those children also for transplant. But I have never used it in a myeloid blast crisis in CML. But if you say so that it's going to be helpful, and of course it's going to be a little more gentle than a standard FLAG-I or 3+7. So probably we will try that since we have good access to venetoclax plus azacitidine as well.
There was a
Oh, she has plenty of SIPs, and we are ready to do their typing. I'm so sure we'll find a match donor, then we won't have to go for a haplo match in transplant.
So another suggestion from my side is that for every blast crisis, we do go for flow cytometry, because in 75%
this is diagnosed on flow cytometry only.
Yeah, and we have noticed 2 MPALs as well. Mixed phenotypic acute leukemia post CML. So majority is AML, blast crisis, myeloid blast crisis. 25% are lymphoid blast crisis, and 2 to 3% are mixed phenotypic acute leukemia, which are then not very sensitive to hypomethylating agent and venetoclax, and we have to give FLAG-IDA in those cases, FLAG-IDA or FLAG-DONO, whatever is available, with ponatinib, of course.
There was a paper published last year in Lancet Hematology by Nicholas Short and colleagues from the MD Anderson, looking at the triplet of decitabine, venetoclax, and ponatinib in patients with myeloid blast phase CML, and they got really good results with it, but they had problems with cytopenia, so they did have to dose reduce. So it might be worth having a look at that paper as well. And there's also Philippe Rousselot's data on ponatinib with azacitidine as well as a combination. Again, it seemed to be better tolerated than the triplet. So there's a couple of options that are not FLAG-IDA or DA3+7.
Yes, very interesting paper. I went through it. And another suggestion is that we can reduce the dose of venetoclax. Rather than giving for 28 days, we can do 7+7. We can do 14 days venetoclax. So all these are options for CML blast crisis, but it has to be followed by transplant.
Yeah, we might be able to share those references with the audience afterwards with our little post-event package.
Thank you very much. I think we can go to the second case from Brigadier Mehreen.
Super. Thank you very much. That was a great case, Raghu, and a wonderful discussion. Professor Ali Khan, Mehreen, would you like to please share the slides for your first case with us?
Yeah, first of all, I would like to thank iCMLf for encouraging all of us from low and middle income countries, Southeast Asia, to share our difficult cases. So I have 2 cases. I have my 2 brilliant registrars. I would first like to invite Dr. Fahim. Dr. Mohammed Fahim is my registrar. He would present the case and followed by then second case. So Dr. Fahim, kindly share your slides.
While the slides are coming up, I'll say it's always an honor to work with you and to work with our physicians in low and middle income countries. I'd really like to thank Professor Copland, Mhairi. Unfortunately, Dr. Jeff Lipton still hasn't been able to join us. I'm not sure what's happened there, but Jeff is always a great contributor and very timely. So something has happened there which has prevented him joining us. And Professor Mhairi Copland will step in as the international expert. Thank you. Dr. Fahim.
Hello, am I audible?
Yes, audible.
Hello. My name is Dr. Mohammed Fahim. I am resident in clinical hematology at Armed Forces Bone Marrow Transplant Center. I am the resident of Brigadier Mehreen Ali Khan. I am presenting a case of a 52 years old male with no previous comorbidities. He first presented to Armed Forces Bone Marrow. He first presented to Armed Forces Bone Marrow Transplant Center in April 2024 with easy fatigability, night sweats, and weight loss. On examination, his spleen was palpable 5 centimeters below the costal margins, and his so-called was 1.9, means he was high risk. So we did workup. On CBC, he had a leukocytosis with WBC count of 51,000 multiplied by 10⁻⁹ per liter. His hemoglobin was 9.8 gram per deciliter and platelets were 353. So bone marrow examination was done and it revealed CML and accelerated phase with 10% blasts. His cytogenetics were done and it showed 46XY with 922 translocation. His PCR per BCR ABL1 P210 was positive and it was 26.68%. So he was started on nilotinib at 100 milligram per day. and he was advised PCR per BCR ABL1 at 3 months interval. At this time, we had a plan. So his fully matched HLI-matched donor was available at that time. Our plan was to perform allogenic bone marrow transplant after CR1. He had then follow-up visits and follow-up visit on 10th of June 2024. He had WBC count of 3.2. His hemoglobin was 13 gram per deciliter and his platelets were 13,000. So we decreased the dose of nilotinib from 800 milligram per day to 600 milligram per day. And further follow-up visit on 12th of August 2024, his WBC count was 3.8. Hemoglobin was 14.4 gram per deciliter and platelets were 220,000. He was advised nilotinib 800 milligram alternating with 600 milligram per day. At this time, his PCR per BCR ABL1 was done at 3 month interval, and it showed optimal response. He had another follow-up visit on 16th of September 2024. This time his WBC count was 5.0, hemoglobin was 13.0, and platelets were 194. So nilotinib dose was escalated back to 800 milligram per day. Next slide. He then presented to AFBMTC and with complaints of fever and orthopnea for 10 days. On general physical examination, he had erythematous maculopapular lesion on both arms, which was leukemia cutis, and his systemic examination showed dull percussion note and absent breath sounds on the right lung basis. Other systemic examinations were normal. And we did workup, and his CBC showed WBC count of 21.6 thousand. His hemoglobin was 13 gram per deciliter, and his platelets count was 17,000. His peripheral smear showed 45% blasts. His bone marrow examination was done, which was Sudan black positive, and there were interstitial and focal infiltration by blast, confirming CML transformed into AML. His flow cytometry showed weak CD45 positive, weekly positive, and CD34 positive, CD13, CD33, CD117, CD38, and CMPO double positive. His BCR ABL1 at 6 month interval was done, and it showed 21.9%. So he was started on IV antibiotics like meropenem and vancomycin, steroids and diuretics, and he improved with it. His ECOG score at that time was 2. So we started him on ponatinib 45 milligram and azacitidine and venetoclax. This cycle was complicated by febrile neutropenia, axillary abscess bilaterally, and cytopenia. So because of that, venetoclax was withheld on day 14. He was managed with antibiotics, antifungal, pegfilgrastim, buffycoat, and HLML granulocyte infusion at that time. Next. His bone marrow examination post-azavin was done on 15th of January 2025, and it showed that marrow is not in remission with 14% blast. So at the time of discharge, he was given venetoclax for 7 days. At this time, expert consultation was done from the International CML Foundation team, and experts were consulting. One of them is Jeff Lipton, who is a staff physician on the Leukemia and Allogenic Blood and Bone Marrow Transplant Services, Princess Margaret Hospital, Canada. His opinion was to give him azavin and ponatinib, followed by allogenic hematopoietic stem cell transplantation and early ponatinib maintenance as the patient gets second CP. One of them was Mhairi Copland. She is a professor of translational hematology, University of Glasgow, Scotland. She was of the opinion that if there is no response to azavin, then switch to FLAG-IDA plus ponatinib, followed by allogenic hematopoietic stem cell transplantation. Another one was Fausto Castagnati. He is the professor in hematology, University of Bologna, Italy. He was of the same idea as Mhairi Copland. So as the patient was frail, so we started him on D3A7 and ponatinib 45 milligram. His donor medicine was also given at the dose of 45 milligram per meter square. This cycle was complicated by febrile neutropenia and prolonged cytopenia. as it always does with this patient. So he was managed with broad spectrum antibiotics. His peripheral smear on day 34 of D3S7 showed 9% blasts. So he was readmitted for salvage chemo on 10th of April 2025. This time he had febrile neutropenia and he had decreased air entry bilaterally. And his blood CS was done, which showed no growth. HRCT test was unremarkable and his galactomannan was positive. So he was started on broad spectrum antibiotics and amphotericin as fever settled then. So he was given salvage chemotherapy with flavin from 15th of April 2025 to 21st of April 2025. He was also given iCMLf and ponatinib combination due to their synergistic effect. This cycle was also complicated by nephrotoxicity. Nephrotoxicity was secondary to amphotericin on day 11 of flavin. It was managed with IV fluids and with drug dose adjustments. It was also complicated by febrile neutropenia and the day 12 of flavin, and it was managed with antibiotics, antifungal, and buffycoat infusion. He had also a CV line infection on day 18 of flavin, so we removed the CV line. He also had hyperbilirubinemia on day 22 of flavin, so amphotericin was changed to isovoconazole. His current status is that his blood CP showed a WBC count of 3.4, HB of 8.3 gram per deciliter, and platelets were 18,000. His bone marrow aspiration last done showed that his bone marrow is not in remission. He was on palliative care with antibiotics, fluids, and electrolytes, cytoreduction with hydroxyurea and ceterabine, and blood components. But the patient has now expired. Thank you.
Thank you very much.
Over to Brigadier Mehreen Ali Khan.
Thank you very much, Dr. Fahim. I had many CML patients, but this patient was very, very close to my heart as we were trying to pull him up. He had fully matched donor and everything available for transplant, all the pre-transplant assessment has been done. But unfortunately, with all the efforts, with all the international opinions and availability of all TKIs, we were unable to achieve CR for CML and myeloid blast crisis. So my question to the expert, Professor Mhairi is here, Professor Raghu is here. We are missing Professor Jeff Lipton though. So what you could have done differently for this patient? My first question. My second question is the combination of asciminib and ponatinib, which has reported to be synergistic in few cases, however, not the standard of care. Would you advise that? And third, despite availability of all the resources for transplant, we couldn't take this patient to transplant and he passed away. He was just 52. So my question is what you could have done differently.
Thank you very much, Mehreen. A very complicated case indeed and beautifully presented. Thank you so much to our guest presenter. Barry, would you like to start?
Yeah, so I think this is a very difficult case, and I think you did everything you could and more, and you had access to, I think, more drug combinations and more lines of therapy than we would have. I think the combination of leukemia cutis and myeloid blast phases, the outcomes are really, really terrible. And I've not seen a patient get to transplant with that combination with blast phase CML, unfortunately, and get into remission. I think you did everything you could. In terms of your question about the asciminib and ponatinib, I think that's quite interesting from the data I've seen with asciminib as a single agent. I don't think it's effective in blast phase or in pH positive ALL, but I think potentially in combination it could certainly help with mutation development, reducing mutations. But we wouldn't have access to that. Likewise, we wouldn't have access to Flagida with venetoclax either. So I think personally you've done everything you could for this patient, and I'm really sorry it didn't have a more positive outcome, but I think he had really terrible disease.
Yes, thank you very much, Professor Mhairi, for your valuable comments. We value that. That's why this International CML Foundation Forum helped us out. Whatever we were doing, we were continuously in touch with the international experts. And this was all we can do because there's a certain limit to the medical expertise as well. You're right.
Dr. Raghu, would you have done, what would you have done?
I personally wouldn't have given a CML. I have not much of an experience with that, but in my opinion, anything which has a leukemia cutis, in fact, for that matter, even a solid tumor which has a cutaneous metastasis has an extraordinarily poor outcome. I sometimes feel it is worse outcome than having liver, lung, or brain metastasis. So anything which is in cutaneous metastasis performs very poorly. And even otherwise, even if they're non-chronic myeloid leukemia in blast crisis and you get a leukemia cutis, outcomes have, in my opinion, have been very poor. Nothing seems to work very well. It's something, a disease with a big vengeance on its own. So I don't know if we could have ever pushed this patient to a point where we could have utilized the matched donor at all. And I know you did try in HLA matched Buffy codes as well for the infection. I sometimes hope it actually engrafts, but it doesn't do that in CML for some reason to exploit at least transfusion associated GVHD. It doesn't happen at all.
Thank you very much, Professor Raghu. In fact, in this case, both the times patient was in septic shock on inotropic support, and HLA matched granulocyte really rescued him at that point in time. However, thank you very much for your comments about leukemia cutis. Let's go to our second case, which is another CML in blast crisis and leukemia
Mehreen?
cutis. Yes,
Mehreen, sorry to stop you, but we'll go back to Raghu for Raghu's second case first, and then we'll come to you. So we'll do the cases
thank
alternately.
You.
But
Thank you.
as Raghu gets his slides back up, Mhairi, would you like a closing comment on Mehreen's extremely difficult and rather sad case?
I think you did absolutely everything you could, and unfortunately CML can still be fatal in some patients, and I think a lot of our colleagues don't realize that anymore, and I think this is just a salutary tale that CML can still carry a poor prognosis, and it's really important to do the marrow to get the blast percentage to make sure there's no additional cytogenetic abnormalities, and properly work up these patients, because you knew from an early stage that he was high risk because you'd done that marrow and you started him on a frontline second generation TKI, so you'd done everything you could. So I think he was a very hopeless case.
Thank you very much.
Thank you very much for that discussion. Excellent discussion. Raghu, would you like to?
Yeah, I hope you can see the second set of slides. This is a 70-year-old gentleman who had a long history of type 2 diabetes for about 40 years. In 2021, he was diagnosed to have CML in chronic phase. And at this presentation, he had a grade 3 diarrhea and melena. So at this presentation, these are the investigations. His hemoglobin is 8.3 grams. The total WBC count is 1,89,480, and the platelet count is 36,000. And of course, as I told you, he had a diarrhea and melena. So he had pre-renal azotemia. Urea was 92, creatinine was 3 milligrams, but the electrolytes and liver function tests were fortunately normal. We did a kinase domain mutation. It was negative. The BCR-able RT-PCR was 30%. The bone marrow this time was still in chronic phase. There were no cytogenetic abnormalities on routine cytogenetics. Let's go back a little bit into his treatment history. He was initially on imatinib for 400 milligrams daily for 2 years. He had very frequent thrombocytopenia, and the leukocytosis never actually came down. So he still maintained a count over 10,000 to very occasionally reaching 20,000 and above. So it was abandoned after 2 years. He was then changed to dasatinib, although there was no IRMA mutation. And he was given 50 milligrams of dasatinib. Again, there was no response. The same thrombocytopenia, leukocytosis persisted, and there was no remission in the BCR-ABL at all. And he was then changed to bosatinib, 400 milligrams daily. And after he started 400 milligrams of bosatinib, he presented to us with diarrhea and an acute renal failure. For his diabetes, of course, he was on glimepiride plus metformin. Metformin 3 times a day and glimepiride in the morning along with breakfast. And of course, he was taking bosatinib just 2 weeks prior to his coming here. So when he came here, we held the bosatinib because of the renal failure. But fortunately for us, we hydrated him and quickly brought him under the acute renal failure under control, and we could recover the entire renal function back to normal. So the dilemma is he has a failure to at least 2 TKIs, I should say. We haven't given bosatinib for quite some a good length of time, except for 2 weeks. He continues to be in chronic phase. There is drug intolerance at every occasion. There is no IRMA positivity, and we would like to know what would be the appropriate drug now.
Thank you very much, Raghu. Another very complicated case, beautifully presented. Mhairi, would you like to open?
Yeah, sure. So this is quite a common occurrence, unfortunately, that we get patients with multiple intolerances. So just for me to fully understand, he didn't respond to the imatinib and that he didn't go into complete hematological remission.
Yes.
Is that correct?
He always stayed in chronic phase. The
Okay.
count was absolutely never below 10,000 at any time.
Okay.
And we did not dare to increase it to 600 and 800 milligrams of imatinib because of the thrombocytopenia. So essentially, the total WBC count never returned to normal, and the platelet count always stayed low. That was the major problem for us.
Okay, and now is his platelet count still low?
Yes, the platelet count is quite low. So it is just about 36,000 now.
Okay, so in order to avoid the diarrhea with the bosutinib, we always automatically start anyone that's getting bosutinib on loperamide at the same time. And in patients that are frail or have known renal impairment, we might start at 300 or even 200 milligrams once a day, and then gradually build the dose up if we can over a period of a few months. I think in terms of other TKIs, the dasatinib in view of his platelet count, I think is challenging, and if his platelet count was 36,000 on or that level with 50 milligrams and he wasn't responding, I'm not sure that going down to 20 milligrams and then trying to build the dose up would help, although that might be better in terms of his renal function. I wouldn't give nilotinib in view of his diabetes. Ponatinib I wouldn't give again in view of his diabetes and his cytopenias. So I might re-challenge with a low dose of bosutinib with loperamide and advising the patient to drink, sort of try and drink 2 liters a day, and see where he goes from there. I think if he's not responding, and you don't have access to asciminib, I think that becomes more.
Asciminib
challenging.
is phenomenally expensive, even under a patient assistance program. But I think it's not available for in the public health system. I work in the public health system.
Okay.
So we do have, imatinib, nilotinib, dasatinib, and bosutinib now available, but we have not yet got asciminib into the public health system. So it will still be very expensive.
I personally would try and optimize his dose of
Bosutinib.
bosutinib, maybe starting, or even if you maybe need to give him some EPO if his hemoglobin goes low, GCSF if his white cell count goes low. I know it doesn't help as
So
much with the platelet,
keeping up
but
hemoglobin with transfusion and giving GCSF is not a problem for us.
okay.
Can we add anything to keep up the platelet count, like how we do with some of the breast cancer?
As in giving a
drugs?
Eltrombopag.
Yeah.
So there's a couple of, I've never done it, but there are a couple of case reports of people giving Eltrombopag to support platelets in patients with CML, but it's not something that I've done.
Okay.
But it's
Or
certainly something that,
romiplastim? Can we give romiplastim?
yeah, that I think maybe it was Eltrombopag or
Okay.
romiplastim, yeah. Yes,
Either of.
it's worth considering if you are able to do that.
Yeah,
I
both
guess
are available in the public health system. So
yeah.
I thought we can give that and try maintaining a lower dose of bosutinib. I will try that
Yeah.
next.
Yeah.
Professor Mehreen, what would you do if this was your patient?
Thank you very much, Professor Raghu, for another very interesting case, more than 70 years of age. So I agree with the continuation of bosutinib at low dose. However, increasing platelet count would not be my objective in this particular case. I have never seen anybody bleeding with a platelet count of more than 30,000. And of course, as Professor Raghu has said, Eltrombopag and romiplastin both are expensive medications. So if this gentleman at 70 years of age is continuing with the low levels of PCR, BCR-ABL with low dose of TKIs, that's fine. We are not hitting transplant in any way.
Arlene, I finally managed to get in.
Yes.
It's Jeff.
Welcome.
Welcome, Professor Lipton.
Thank you. I'm
Welcome.
having a lot of trouble this morning.
That's okay. We're glad that you're okay and you're with us. You are always such a wonderful contributor and very timely. So we were worried about what might have happened to you. So
My
welcome.
link disappeared. It disappeared. Didn't know what happened. Okay.
We
That's
would
okay.
like to see your video as well, Professor.
It's nice to have you here. So we have just been discussing Dr. Raghu's second case, which of course, unfortunately, you haven't seen, but you are now part of the group. Welcome.
Okay.
Just close off perhaps with Dr. Raghu's case, and but we're just sort of in the middle of doing that, but it's very nice to see you.
Okay.
Mhairi, might we go back to Mhairi about this case?
So I think to sum up, it's an older patient with comorbidities. I would re-challenge with the low dose bosutinib with transfusion cytokine support. And I think for this patient, you're maybe not aiming for major molecular remission. You're aiming to keep the BCR-ABL level around 1% or less if you can, and not to add to their other comorbidities.
Thank you. Thank you
Can I
very
just
much.
interject something here? I think people forget that the literature shows that if you can get at least a 2-log response or a 1% response, as Mary just commented on, the survival is the same as if they had a 5-log response. So,
Okay.
you know, are you pushing for TFR? No, I think you need a balance between toxicity and survival. And I think as said, if you can get with low dose bosutinib, even some people respond on 200, and I've even had some on 100 milligrams a day, survival is normal.
Good. That's wonderful to hear. Okay. Bosutinib has just been launched in India by an Indian
Wonderful.
company. We are a little new to that. So the diarrhea
Yeah.
was a little unexpected for us.
The main thing with bosutinib is the ramping up phenomenon. Is don't come up with the full dose right away. Start with maybe 100 milligrams a day for 3-4 days, then up to 200, and then maybe up to 300. You find you might have a response already by 200 or 300, and may not need to go higher.
Oh, wonderful.
So that's something we've learned, and actually there's some literature now on that hardly anybody uses the full dose, and the ramping up phenomenon approach usually eliminates most of the severe diarrhea.
Thank you. Thank you, Professor.
And we make sure all the patients have got loperamide with them when they
Yeah.
start.
Yeah.
Good.
With the ramping up, most of them don't even need it.
Okay. Okay. Right. Thank you. Thank you very much for your opinion. I'll stop sharing my screen so that Brigadier Mehreen can present her
Thank
last
you very
case.
much, Raghu. Yes, indeed. A very, very complicated case and beautifully presented, and what a great discussion. And thank you very much, Jeff, for making yourself known at the very end of that case and still having something very useful to say. Mehreen, can you please get your second case up? And I believe that one of your residents will present this case.
Yes.
Dr. Afshin.
Yes, Dr. Afshin Liaquat is my registrar, very brilliant one, very hardworking, and she'll present a case. So previously we presented the case with leukemia cutis, which we could not rescue. And Professor Lipton also knows that case because he has already given opinion on iCMLf forum. Professor Mhairi also knows because she has also given the opinion as we shared previously. So this is a case of a CML, transformed into myeloid blast crisis with leukemia cutis, which we could, whom we could rescue. So over to Dr. Afshin Liaquat. Afshin, kindly start.
Welcome, Dr. Afshin.
Good evening. I'm Dr. Afshin Liaquat, Registrar Clinical Hematology from Pakistan. I'll be presenting a case of a 29-year-old male with no previous comorbid. He presented to a local hospital in April 2024 with the complaints of shortness of breath on exertion for 2 weeks. The systemic examination revealed a massive spleen. On initial assessment, he found out that there is a leukocytosis with thrombocytopenia and anemia. After initial supportive management with the RCC's transfusion, he was referred to a tertiary care hospital. In the tertiary care hospital, he was again found that there is a leukocytosis along with the anemia and thrombocytopenia. With a suspicion of leukemia, he was given a TLS prophylaxis and advised a bone marrow examination. His first bone marrow examination from the same hospital revealed a primary myelofibrosis. However, there were certain descriptions mentioned that he has a 12 to 15% loss in the spirit. There's a grade 2 to 3 fibrosis, and the suspicion of transformation to acute leukemia was in query. So keeping in view a suspected myeloproliferative neoplasm, he was advised a PCR for the mutational analysis, which was unremarkable, including the BCR-ABL rearrangement. However, the cytogenetics reveal a complex karyotype that is 48XY along with the deletion of 7, trisomy 8, trisomy 17, and translocation 922. He was started on a first generation TKI, that is imatinib, before referred to our hospital. He presented to our institute in May 2024 with the complaints of easy fatiguability and shortness of breath for the last 1 month. But however, there is an additional nodular rash on the trunk for the last 15 days, which was noted. His past medical, surgical, and drug history was unremarkable. On examination, there was an erythematous nodular rash over the trunk, which was likely a leukemia cutis. This is the picture. And abdominal examination revealed a 20 centimeter spleen palpable below the left costal margin. His peripheral smear showed that WBC count was 9.2, hemoglobin was 9.2 gram per deciliter, but the platelet count was 128. There was a marked basophilia, which was about 15% on the smear. With the provisional diagnosis of chronic myeloid leukemia, he was advised a further workup. The bone marrow aspirate was diluted. There was a Gotland refined biopsy with the effaced architecture due to increased fibroblastic activity, but the reticulin stain showed the fibrosis of grade 3. The CD34 highlights the occasional blast cells. The immune phenotyping revealed 3 to 6% of the total population that contains the CD13, CD33, CD117, HLA-DR, MPO, and CD45 positive myeloid cells. The fish for BCR ABL rearrangement was detected in 30% of cells, but the fish for deletion 17p was negative. The skin biopsy revealed myeloid sarcoma. So he was made a diagnosis that he has a chronic myeloid leukemia in blast crisis with a complex karyotype and extramedullary involvement in the form of the leukemia fetus. For the induction chemotherapy, we have given the 2 cycles of decitabine, venetoclax, and ponatinib, along with the antimicrobial prophylaxis. His disease was reassessed after the 2 cycles of the induction chemotherapy, and we found out that on the clinical assessment, there was no skin lesion and the spleen size regressed, and there was only 3 to 4 centimeters now palpable below the left costal margin. The morphological assessment now showed that the basophils are present only to 2% in the smear. The aspirate was still diluted, while the CD34 highlights only the endothelial lining cells. There was normal fish study with no evidence of BCR ABL rearrangement, while the PET stain showed no evidence of malignancy or marrow uptake. For the consolidation, we have obtained the allogenic stem cell transplant as he has a fully HLA matched sibling donor available. To bridge the transplant period, we have given another cycle of the Decida venetoclax. On 12th of November, this patient underwent allogenic stem cell transplant with a fully HLA matched brother with no ABO mismatch. We have given a myeloablative conditioning regimen that contained the busulfan, cyclophosphamide, and ATG. A total stem cell dose of 2.21 into 10 raised to power 6 per kg was infused, while the cyclosporine and methotrexate was given in a GVHD prophylaxis. His post-transplant period was complicated only with a mucositis of grade 2. He achieved neutrophilic and platelet engraftment on day plus 15 and day plus 17 respectively, and after that he got discharged. On day plus 30, we have assessed the graft function that revealed a complete donor chimerism in whole blood and CD3, while there was no BCR ABL rearrangement was detected on the Fisher study. On day plus 44, when he was on cyclosporine 150 milligram BD, and on the count recovery, we have started the ponatinib 15 mg/OD. He got CMV reactivation, for which we have started a valganciclovir. On day plus 83, the valganciclovir was stopped with the 2 consecutive negative CMV PCRs, while the cyclosporine and ponatinib was continued. However, on day plus 90, while assessing his graft function, we found out that he has a mixed donor chimerism. That is, in the marrow, it was 89%, CD3 was 81%, and CD15 was 84%. Keeping with this presentation, we have started the tapering of the cyclosporine, while the ponatinib was increased from 15 mg to 45 mg OD, and we planned DLI. On day plus 91, he was given the first dose of a DLI with the 5.5 into 10 power 7 per kg. His CSA at that time was gradually tapered, ponatinib was continued, and he has a stable blood counts. On day plus 134, again the graft function was assessed that revealed a complete donor chimerism in the whole blood. However, there was a mixed donor chimerism still present in CD3. At that time, this patient was on the cyclosporine 25 mg BD, while the same dose of ponatinib was continued and has a stable count. Keeping in view the graft function, we have given the second dose of the DLI in form of 1.1 into 10 to the power 7 per kg dose on day plus 155, and we omit the cyclosporine to enhance the GVL effect. On day plus 186, he was on ponatinib with a stable count. On day plus 195, again the graft function was assessed. There was a complete donor chimerism in CD3 and CD15. This patient has recently last follow-up visit in outpatient department on day plus 223. He is clinically improved. He has a stable count, and he is only on ponatinib 45 mg/OD. That's all for me. Thank you.
Thank you very much, Dr. Afshin. Mehreen, would you like to quickly summarize the key issues and questions around this case, and then we'll move on to Jeff for first comments.
Thank you very much, Dr. Afshin, for a very nice case presentation. This young guy, 30 years old male from a small town 300 kilometers away from Islamabad, that is the capital, came to us. The first point I want to highlight for the residents is diagnostic dilemma. So it's not always BCR-ABL positive. Sometimes we have cryptic translocations which could not be picked by PCR, and this was FISH, which was positive, and cytogenetics revealed 922 along with complex karyotype, and finally we reached at a conclusive diagnosis of CML in AML, CML transformed into myeloid blast crisis. So for this, we gave, as you saw, hypomethylating agent with venetoclax, that is BCL2 inhibitor, along with ponatinib. It worked very well. The patient was brought into CR and fully HLA matched donor transplant was done. After transplant, we faced the challenge of mixed donor chimerism, which was solved by DLI, and escalating 2 DLI were given. And the patient is feeling very well in himself. He has joined his office, he's enjoying his children, and he is on ponatinib 45 milligram daily, and we plan to continue it for 2 years. So my question from Professor Lipton is, for induction of CML transformed into AML, would you prefer hypomethylating agent venetoclax and ponatinib, or would you directly go to DAR, that is D3A7? And second question is, would you like to give the third DLI when the chimerism is complete, or would you stop there as we did? Thank you, Professor
Great
Lipton.
questions.
And
The first thing I want to comment is something you mentioned earlier, which I think is really important, and that is doing cytogenetics and molecular. I think a lot of part of the world, particularly in the Western world, has now gone to CML diagnosed on a molecular. No one ever does cytogenetics. And there are cases like you have shown that are extremely important. Also, suppose this person had been diagnosed in chronic phase and did well, then lost response, and then you did the cytogenetics and showed what you showed here. Was this here at diagnosis, or did this occur on therapy? And that makes a big difference. So I'm a big believer you must do cytogenetics. Also, the fibrosis was there. You must do a bone marrow because you're never going to detect fibrosis without it. And in fact, in a lot of cases, when people don't recover blood counts when you initiate a tyrosine kinase, one of the first things you should be doing is doing a repeat marrow to show that it's not fibrotic, and that is the reason. So you made some great points there. In terms of induction regimen, I'm not sure that anybody has randomized a study to show anything different. I think what's really important is to use the third generation TKI right up front, which you did. I think that's really an issue. I noticed in a previous case, maybe you discussed that nilotinib was used in blast crisis. And, Novartis never sought approval in most places for blast crisis for nilotinib. So ponatinib is definitely the way to go. Now, here's where I think I would do everything you did, I would agree completely. Here's where I differ. What is the most important aspect in terms of treating CML with a stem cell transplant? It's not the dose intensity, it's the graft versus leukemia. In fact, there is now some literature out there which has compared reduced intensity transplants to full myeloablative and shown no difference in outcome when the patients are the same. What I would have done with this individual would have probably have started tapering cyclosporin by about 6 to 8 weeks. And in the absence of GVH, I would have had him off cyclosporin completely by 3 months. That may have also helped with your mixed chimerism issues. Because what are you doing with DLI? Exactly the same thing as you would be doing by reducing the cyclosporin. So one of the things you did is you kept them on cyclosporin and gave DLI, and these are really competing events. I would normally not give someone DLI until they were off cyclosporin. So in this gentleman, I would have probably tried to get him off the cyclosporin by 6 to 8 weeks. In the absence of GVH or still having issues with mixed chimerism, then I would come in with DLI. The DLI would do 2 things in this case: help with your mixed chimerism, but also helped with an anti-leukemia effect because it may generate some graft versus leukemia. So I think there are those issues. In terms of coming in post-transplant with your ponatinib completely. I think the literature isn't out yet on how long to continue the ponatinib. And that's really very interesting. It's really controversial. And I know with Philadelphia positive ALL, people are now talking about truncating ponatinib at about 2 to 3 years. I'm not sure with blast crisis CML there's any literature to suggest it. And I probably would continue ponatinib indefinitely on this individual. And I think you could probably go with 15 milligrams daily. So I think the big issue is, I think, get the graft versus leukemia effect. And the way you do that is get off immunosuppression. So that, I think, needs to be done promptly in the absence of GVH.
Thank you so much, Jeff. We'll move on to
Can I
Margaret.
ask you a small question? What is the role of the other cytogenetic abnormalities in this? Do they have any bearing or no bearing whatsoever?
Additional chromosome abnormality?
Yeah.
Well, only that they're
doesn't matter. Doesn't matter at all.
I don't think it matters. They're typically associated with blast crisis, as always generates additional chromosome abnormalities. So they may very well have been that this gentleman missed the whole chronic phase, was moving into blast crisis, and had already developed these additional chromosome abnormalities. In fact, new chromosome abnormalities are really a hallmark very often of what we used to call acceleration, which has now
So do we
disappeared from the
continue
world.
monitoring them, Professor Lipton?
No. I think you monitor BCR-ABL. That's all you need to monitor. I
Thank you.
think if there shows any sign, however, that response is being lost, he becomes cytopenic, or you start showing some funny differential, I would repeat cytogenetics again, totally looking for those things. But otherwise, I think your primary marker is going to be BCR-ABL, as I think you're doing.
Thank you very much, Professor Lipton, for your very, very valuable comments. Yes, we should have started cyclosporin tapering earlier. In our institute, the policy is to start tapering at 90 days, which we are thinking to shrink to 8 weeks. And by day 120, the patients are off immunosuppression. So that's why
I think
I completely agree with GBL effect.
I think that's patient driven. I think if you got a really high risk patient, I would get them off earlier. And there actually is some literature which has compared the CML relapse and cyclosporin that's been tapered after 6 months and cyclosporin that's been tapered before 3 months. And the relapse rate definitely goes up with a late taper.
Yeah. And a very important question, which you already mentioned, taking ponatinib for 2 years post-transplant at the dose of 45 milligrams, it's very hard for the patients. So with your advice, I will start reducing ponatinib to 30 milligram and then 15 milligram daily, but I will give for 2 years in this gentleman.
No, minimum of 2 years.
Yeah, minimum of 2 years.
As I said, with blast crisis, I don't think we know how long, but I think there's no evidence that's come out, at least in chronic phase disease, that if you get a good deep response, by tapering down to 15, tapering down to 15 is, well, FISH, remember, is only a 1% sensitivity. So, if you can do moleculars, you're probably better off. But I definitely think that that's the way to do it.
So inviting Mhairi into the conversation, and I'll draw attention to a question from Asma Nasir saying, "Good evening, everyone. My question is, as routine cytogenetics can miss some cryptic mutations, should we advise FISH testing on all the patients of CML?" So taking that question with you and inviting your response, Mhairi.
Okay, thanks, Arlene. So in answer to the question, we would do FISH if we had a negative qualitative BCR-ABL result, and if cytogenetics failed, we would try to do FISH, but we wouldn't always do FISH if we got a positive result from either qualitative BCR-ABL or cytogenetics, but we would always do the cytogenetics to look for additional cytogenetic abnormalities. In terms of the last case, I think it's a really nice case to finish on because it's got a positive outcome. I think we tend to start tapering the cyclosporin around day 60 so that patients are off cyclosporin by day 100, and we try to restart TKI around day 45 to cover the, but it's not always possible because patients might still be cytopenic, they might have abnormal liver function. So we probably only manage that in about half of the patients. I think with ponatinib in particular, after transplant, especially maybe a TBI-based transplant, we're really concerned about accelerated cardiovascular disease with a 45 milligram dose of ponatinib. So we would monitor the BCR-ABL level, and for patients where it's less than 1%, we would reduce the dose to 30 milligrams and MMR to 15 milligrams. And I think how long you continue it for is very difficult. So I have a patient at the moment where I'm probably never going to stop it, and he's on 15 milligrams on alternate days because he had a T315I mutated blast phase which occurred on treatment, and I'm too scared to stop. But he's back at work, he works full time, he's very well, but I'm very conscious of his cardiovascular risk, and there's other patients that have had to stop after a couple of years because of chronic side effects, even at the 15 milligram dose. But I would try and keep it going for at least 3 years if I could post-transplant, and some patients indefinitely.
Yeah, you are
See,
very right.
the first thing we all do is taking our own pulses here because we don't know what to do. So what Mary has said, I completely. I think Mary brought up an interesting point: is the role of FISH. FISH does not replace cytogenetics. FISH is a molecular test for the one probe that you're using. So if you're using BCR-ABL, it would miss everything else. So unless you're using a whole spectrum of things, you're not going to pick it up with FISH. I think the bone marrow and the molecular test at diagnosis are important because, as this case showed, you have a cytogenetic test with negative molecular. There's probably not negative molecular, probably has unusual breakpoints which occur in about 5% of patients. And unless you use patient-specific primers, you won't pick this up. The commercial kits will not pick it up. On the other hand, you also get cryptic cytogenetic abnormalities, so that if you have people with normal cytogenetics, apparently, but molecular positive, but BCR-ABL, they're about 5%. So this is why you do both. Now, where does FISH have a role? FISH may have a role in a case where you don't have a molecular, so you follow up by FISH. But remember, with molecular, depending on your assay, you're looking at MR4, MR5, or something like that as sensitivity. FISH is only MR2. So I've had patients like this. It's the best you can do because iLab wouldn't make patient-specific primers, but that's all you can do. But it is remembered and not anywhere near as sensitive as doing the molecular. So I think Mary made some really great points there. Do them both and follow with what you can, but remember things like sensitivity.
And another point I would humbly like to add is that whoever has cryptic translocation is not a candidate for TFR. So patients with cryptic translocation, which cannot be picked by PCR, BCR-ABL, which is the quickest test, so they are not the candidates for TFR.
Agree,
So I completely agree. Yeah.
And remember as well, the whole thing, I think the Italian group and the German group had some great data on this. Remember, there are patients at diagnosis who present with additional chromosome abnormalities, high and low risk, and they do respond to treatment just as well as the ones who don't, but maybe the durability of the remission isn't as good. So that's another reason to look, is because if you find someone with an additional chromosome abnormality, you may want to watch them a little more closely. So if you've got someone who has a great response, who you normally would be monitoring every 6 months, someone like that, I may monitor every 3 months. But remember, that does occur in about 10 to 15% of patients. There are additional chromosome abnormalities at diagnosis.
Raghu, you asked some interesting questions earlier, but would you like to give us your broader thoughts and views on this case and the matters discussed around it?
Phenomenally helpful learning points from all of you. looked like a very difficult case to treat, but I do agree about this early withdrawal of cyclosporin. I still remember doing that in the earlier days, but sometimes the GVHD can be overwhelming. So most Indian physicians tend to give it a bit longer than what Professor Lipton has voiced. Something like what Brigadier Mehreen has said, to up to 100 days and then start tapering. Yes, I know that that is what we have been doing, but I will keep this in mind and see if that is possible to withdraw it earlier if you are getting a chimerism earlier. So that seems to be a very good point. I did understand that we are defeating the purpose of holding on to a full dose of cyclosporin and then giving DLI. So one seems to defeat the other's role at the same time. So possibly the best way to go about doing that is lower your dose and then get a GVA graft versus leukemia effect, and then see if there is still a crop up of the chimerism, try the DLI. So that's a very good learning point for me.
Thank you. Mehreen?
Thank you very much. I would like to thank iCMLf and especially Professor Lipton, Professor Mhairi, Professor Raghu, and Arlene for such a fruitful discussion, especially for our resident, junior consultant, and for ourselves. So every day is learning, and we should never stop learning. So it was a wonderful discussion, and I hope to continue such discussions in the future as well. Thank you very much.
Thank you very much to our presenters. Jeff and Mhairi, would you like to have some closing comments?
No, again, my apologies for not being able to log on right away. I don't know what happened, but no, as usual, some really great cases and some wonderful learning points just on that second case, without even knowing what went on the phone. So I think it's really important to learn some of the things. Don't do things that may be conflicting, and don't take shortcuts as some people are tending to do. And because I think this is a case which not taking the shortcut led you to your diagnosis.
And just to add to that, I think it's been 4 really interesting cases, and I think as well they really highlight the importance which you did of fully investigating the patients at the start and having all the information such as the cytogenetics and the BCR-ABL and knowing the comorbidities. So I think that's really important so that you can risk stratify the patient from the start, but they were great cases. So thank you very much.
Raghu, would you like a last comment?
Wonderful discussion. Lots of learning from everybody who participated, especially from Brigadier Mehreen for me and Professor Copland and Professor Lipton. Of course, I've heard Professor Lipton from 1992 when I spent my first ASCO there with and the transplant unit there for in 1992. Yes, I was there in Princess Margaret. So you have changed quite a lot. But yes, I think you have voiced more. In the past, you used to be quite silent, if I remember right, in the clinical meetings. But now I can hear him very well, very often in our iCMLf meetings. Wonderful then.
No one's ever accused me of being too silent.
I did not know about that pre-existing relationship, and I find that so hard to believe. Thank you.
If you allow, I would like to encourage our youngsters as well. As Professor Raghu has mentioned, Dr. Hafsat Tabassum, who picked up cases for Professor Raghu, busy HODs have very less time to pick the cases. And my registrars, Dr. Fahim and Dr. Afshin Liaquat, it's 8:10 p.m. in Pakistan, and they are supposed to be in the hospital at 7 a.m. So it's 13 hours on the campus. So we would like to encourage all the registrars for more learning and words of wisdom. Professor people like Professor Lipton are here, Professor Mhairi is here, so that they should get as much knowledge about CML as they can.
Remember,
Thank you very
remember, we're
much.
not just here. The email is great. You know, unless you want an instant answer, you can always email questions. And I'll be happy to get back to you with comments. So, you know, you don't have to wait for a special occasion in order to do that. I think I do that. You know, I have my
Thank you.
go-to people around the world when something is strange to me because no one knows everything.
Yeah.
No one
Thank you
knows
very much,
everything.
sir.
Absolutely. And that's a wonderful note to finish on. And that's where the International CML Foundation takes much of its being. We are incredibly well connected, as you can see. Any questions, any issues, any difficult cases, if you don't have direct connections to Professor Mhairi or Dr. Jeff, please come to me through the iCMLf and I will make sure that we get a response to your case. I'd like to thank all of our excellent experts tonight. Mhairi Copland, Mehreen Ali Khan, Jeff Lipton, Digumarti, our guest presenters, and to you, the audience. Clearly, there have been some technical problems tonight that Jeff has encountered in getting on. I've stepped into the hot seat. I was not meant to be our moderator tonight, but it's been an absolute pleasure to be here. But Dr. Sharma hasn't been able to join us. I hope he's okay. Yes, I think we've had some technical issues, but a fantastic conversation. And of course, even for those who have been unable to join us live in person, we will share a link to the recording of this conversation. We will follow up with some post-discussion materials. Thank you very much to our experts. Thank you to you, the audience. I hope you've enjoyed the conversation as much as I have.